Hi, everyone. Welcome back to UCLA Health's podcast, Medically Speaking. I'm your host, Dr. Eve Glazier. If you've ever left the doctor's office and thought, wait, I forgot to mention that main thing, or I'm not even sure what the plan is, you're not alone, especially when you're anxious, in pain, or just tired. Here's the promise of today's episode. You're going to leave with a practical playbook for getting more out of your healthcare visits, what to do before you go in, what to say in the room, and how to leave clear on what happens next. But let me say this out loud. The burden of making healthcare work should never fall on you as the patient. These are just tools about partnership, clarity, and keeping the conversation going after you leave. There is no such thing as being a perfect patient. To help us do all this, I'm joined by Dr. Shaun Sekhon. Shaun is our Chief Cardiology Fellow at UCLA Health, and he's got that rare combination we love on this show, clinical excellence and communication excellence. Shaun, welcome to Medically Speaking.
Thank you so much, Dr. Glazier. I'm so appreciative of being here. I've grown up around medicine my whole life, and one of the things that has always been part of the path has been like communication, discussion with folks, and I think that's a special thing about our job. And I appreciate you bringing me in and having an exciting conversation about this topic on how to help our patients navigate the clinic visit.
I'm so psyched you're here, and first of all, you have to call me Eve. Okay, we're starting with you. What brought you to medicine in the first place?
Well, my father is a cardiac surgeon. Shout out to Dad. He just retired on Friday.
Oh, congrats.
Yes. So he had a long career, and growing up, often I would spend weekends with him in the hospital. So my mom would be busy doing everything that she did to help make sure our lives move forward. And my dad would take me on rounds, and he would check on his post-operative patients, but sometimes he would do procedures. And there was literally times where he would go to the operating room and drop me at a nursing station, and I would hang out with the nurses and joyfully hear what they're talking about patients, how they try to facilitate care while they gave me some candy, which always made me happy. And then literally sometimes he would leave me in a patient room with a patient, and I would just talk to patients. The third place I would go is the physician lounge, which was like a secret place for me as a child that I absolutely loved, like a free access to a fridge and a TV with sports on Sundays, watching the NFL. But it drew me to medicine because I saw my dad do these complex procedures, or I saw that he would go and do these complex procedures when I was a kid. And the special part, though, was always when he was talking to patients and talking to people. And I think there was something where he, after reflecting as I got older, he had a different connection with what it means to be human and how to relate to other people. And he came from a very different background from these people, but was able in an instant to meet them in the current state that they're in. So I found that pretty inspiring. So I owe a lot to him. Both my older sisters are doctors, and let's just say I've had a lot of help and guidance to get me somewhere where I feel like I really belong.
I love, though, that the communication is the cornerstone. At least it sounds like, within your family and yourself have really, what has brought you to medicine and probably kept you in medicine. And actually, you and I were connected through our communications professor at UCLA Anderson School of Business, where you're also getting your MBA. You're a chief fellow, which means obviously you're absolutely a doctor. You're still considered to be in advanced training. I think when our patients hear the word trainees, it's pretty confusing and actually probably sounds meaningless. What do we want our patients to understand about who they're meeting in a teaching setting? And so, most of our guests on the show are UCLA Health physicians, providers, nurses, and guests, and that's what we call an academic teaching center. Can you take our listeners through, maybe even just starting with medical school, going towards an attending, who are these people, what are their roles?
Yeah, absolutely. And I do want to touch, before I do that I think we should empower our patients to be comfortable asking who they're interacting with. Because I think you're right. An academic teaching center flips the script, and you're going to see a lot of providers on different training levels all going towards the path of being an attending physician. But to take a step back, to become an attending physician, there's steps. There's signposts that you have to pass on the road to becoming an attending physician. And being an attending, just to set the definition, is once you're board certified in your specialty, you've gone through the proper training, you are, I guess we can say, the head honcho of the patient's care. You are taking care of everything, and you're the attending. But to get to becoming an attending starts with these steps. First, you go through medical school, 4 years of training. The medical school curriculum has changed, I think, quite a bit since I've been there. But you do 4 years where you go through standard curriculum that everybody goes through during the school years. And then you have some time for self-exploration and deciding what you want to do. When you leave medical school, you go through a process called the match, and the match essentially matches you to programs around the country to do the residency of your choosing. And one of the things that I don't think many people know is just how many different residency programs there are.
I'm sure they don't.
For example, I'm in cardiology. To go through cardiology, you go through internal medicine, which is a big pathway for a lot of physicians on their path to becoming an attending. And through internal medicine, you can specialize into cardiology, heart health, pulmonology, lung health, endocrinology, rheumatology, working on the joints. There's so many pathways that go through internal medicine, but then there's general surgery, and all the surgical subspecialties have their own residency. But to move forward, we go through residency training to complete our residency, and during residency, you are a resident. And most, on average, residencies are about 3 to 5 years on average. And during that time, your title is a resident. First year is often intern year.
I'm just going to interject because
please.
resident, why are they called residents? Because we used to live in the hospital.
I know.
Yeah, you practically do now anyways.
Yes, it's
Sorry
true.
to interrupt, but I was like,
No,
oh my God,
I think
why
it's
are
fair.
they called residents?
I think the life of your the life that you live as a trainee is very different in each stage.
Yes.
And even broken down into residency. Your first year of residency looks very different from your second and your third or fourth and your senior years of being a resident.
Exactly.
And once you get towards the end of residency, whatever subspecialty you are training in, you take an examination to become board certified in that residency. So, for example, going back to me and my colleagues who are in cardiology training, like myself, we are board certified internists. But after we finish residency, if you want to do more specialization and do more specific training, you apply for a fellowship. You go through the match again, and like myself, sometimes you're fortunate to end up at a great place like UCLA, obviously biased, but then you become a fellow. And then a fellowship's often a little shorter than residency training. Sometimes it can be as short as a year. Some of cardiology training is 3 years, so sometimes it's multiple years. And you move from residency to becoming a fellow. Becoming a fellow often is a fantastic role. Again, biased, I'm a cardiology fellow, but you get to quarterback teams. You get to really focus on educating medical students and residents, and you work as a mini attending. So you really get a lot more decision making and for your patients, and you really get to drive and dictate care, which is really, really special. And then through fellowship, after 3 years or however long the fellowship training program is, you end up becoming an attending physician. But I think it's important because often patients at UCLA, specifically at these big academic centers, are going to interface with a lot of different trainees at different levels. And one thing I would like to say, even you can cut me off, as you can tell I like to talk, is there's a lot of evidence that working with trainees is a really special thing for patients, and I don't think we share this enough. Trainees have more time to spend with patients, so you're going to get better histories as a patient, and you're going to have multiple people looking over your case, thinking through the chart, thinking about you critically. And in a training hospital, it's really evidence-based because there's so much of our workflow that is prioritized to making sure our trainees are getting educated in a way that can make them successful doctors in the future. So that makes us really critical about how we think about our patients and are we treating them in a way that has been proven to be beneficial. So I think there's a lot of great things about being in a teaching hospital, and I think there's a lot of navigation that patients have to go through. But one thing I would like to tell patients is, you have a lot of people in your corner.
That's right.
You have a big team.
I couldn't agree more. I mean, also too, and you're so emblematic of, that's why, I'm so excited to even have you on today, because I think it's just you representing just this up and coming generation, I think is going to be so encouraging, reassuring, and inspiring for patients. This is the face of medicine. And I agree. I think sometimes people are like, who's this rando, in my room? But, to your point, you can always ask, who are you? And, what's your role? Never be embarrassed. It's all about you as the patient. But the teaching hospitals, it's really team-based care. As you said, evidence-based, meaning that, you can define evidence-based in a minute, but I mean, there's so much supervision and accountability within these structures. And I mean, by the way, you even taking us through these pathways, often these whole teams come in patient rooms. Sometimes in the clinic setting, a trainee, a resident or a medical student or a fellow might come in and talk to you first before the attending, as you mentioned, the head honcho comes in. But all of this really lends itself to a lot of discussion, I think, thoughtfulness, and learning. And the best, environments I've seen is when the attending is teaching the team in front of the patient and brings the patient into these conversations.
100%. I think the way to think about it is you have a big medical team, but you're still the center of it.
Absolutely.
Right? So instead of it just being a direct conversation from like B2B, from patient to doctor, it is patient being surrounded by multiple people on the same team.
That's right. Absolutely.
And I think it's like very holistic.
Okay, let's talk about what doctors are doing in their heads. We're going to give a little quick glimpse because I think it's nice to demystify sometimes what's happening on our side of the stethoscope. When a patient starts even just telling you their story, meaning, something they're worried about or a symptom, what are you just listening for?
Yeah, I love this. I think we can even frame it as like when the patient starts setting the agenda of the visit. Obviously, patients come in and rightfully so are going to discuss initially the things that's on their mind. Mm-hmm. As a physician or as your doctor in the clinic, you are multitasking in the sense that you're thoughtfully listening, picking up on key words. A lot of the times we are looking for tempo. How long have things been going on?
Right.
Is this something that's slowly building up or something that started suddenly? And like key descriptors or adjectives of a main complaint. So I think just to break it down for patients, just to make things simple, a lot of times we think of, okay, what is the main complaint, the main symptom? And I think complaint's even a harsh word.
Let's even stop on that.
Yeah.
I want people to know, we're taught in medical school to take a, quote, history. And the first, kind of slot is what's the chief complaint, and obviously we don't think you're complaining.
No.
That is just a medical word. This is just literally how we're taught to sort of say, like, why are you coming in today? And we see this. I want our patients to know this. We see this on our schedules. It'll say, why are you coming in, or chief complaint.
Correct.
And often the person checking you in, like a medical assistant, often, I'll walk into a room as you do, and it'll say chief complaint, shortness of breath,
right,
or a rash. So no, we don't think you're complaining,
Absolutely
but it's a
not.
way to succinctly sort of like anchor us. So I just want everyone to know that.
Yeah, exactly. I think the way to think about it is the way we were trained. The chief complaint is to the same point of what's your main symptom.
Exactly.
And I think it has a different connotation than what we use in everyday life, but it helps anchor our conversation. So going back to this, in terms of how patients can think about what doctors are doing in the mind, it's one, what is the main symptom they're discussing? What's the tempo? And then what are the descriptors? And I think a really important thing for patients to know is while we're listening, we're forming thoughts at the same time. It's kind of working in parallel. Like our brain is trained in a way where we're listening actively, but at the same time, while you're listening, you're critically thinking about what are the things that could be causing this symptom. Are there certain descriptors that make you more concerned? And then it's even more downstream of that. As the conversation moves forward, as the patient continues, you're starting to think about, okay, how am I going to treat this symptom, and how are we going to work together with the patient in the context of their life to move their care forward? Yeah. So it's a lot of parallel work happening in the mind at once.
I think it's really perfect to share this because, on one hand, I think it's really, interesting for people to know, like, you know what I mean? Because what you're sort of internal agendaing as the doc, no, that's not a real word. But on the other hand, I think patients often feel, and definitely not with you, but I think patients sometimes feel, oh, I'm just sort of, trying to answer questions to their agenda, and I also have my own agenda, you know what I mean, in terms of talking. Which brings me to, I think why don't we build together like a patient playbook?
Right.
And we can even just start, we'll do before the visit to start. Yep. Because I think a lot of people want to prepare, but they're not sure what's helpful. And again, we're not placing the burden, but we just want to kind of give some tools. they don't want to forget things, and they also don't want to like walk in with like a 14-page manifesto. So what does good preparation look like? And by the way, I can't speak for you, but I'm a patient, a lot of my life too. So we're thinking structure, but without any pressure to perform. So let's get your thoughts.
Yeah, I think this takes me back to our connector, Bob McCann, and talking about communication in our classes at the Anderson School of Management. Because I think for patients and for doctors, it's very similar. It's the first thing is like, who's your audience, right? And I think the first thing to do is when you have a clinic visit coming up is being really cognizant of who are you interfacing with. Is it the coach of your medical team is your primary care doctor, for example, the quarterback of your team, the home base, or are you speaking to a specialist? And having an understanding of what your prior conversations have been with them, or if it's your first time visiting them, why have you been referred to them, and where they're coming from, right? It's the same thing on the physician side when you're seeing a patient is who's your audience, what's your prior relationship with them, and how are you going to approach the conversation. I think taking a step back is just who are you speaking to, and then again setting an agenda for yourself. I think it's really important to think about the top 2 to 3 things you would like to get from a visit, because I think this is really important to talk about is how do we set our patients up to use a finite period of time and set them up for success. So I think doing some work and thinking through things beforehand can set things up really, really well. And even to make it a step forward, I think it helps the patients dictate some of the conversation, right? And I think that's a really healthy part of the partnership between a physician and a doctor is for patients to feel empowered to come in and be like, I'm here today because of X, Y, and Z. And before we talk about certain things, I just want to let you know these are the top 2 or 3 things that I was concerned about. Right. Or I would love to talk to you about and hear your thoughts.
I love it. I mean, I think, why don't we just do an example? Because I think that might be helpful. So let's say I'm coming in and my quote chief complaint is shortness of breath. Right. I mean, if let's say I'm at home, I'm a patient and I'm finally get to see you. I'm very excited. I'm having shortness of breath. So that's my headline. Right. I think we kind of talked about trying to focus a little bit. My audience is a specialist. That's you. Right. Yes. By the way, everyone, I hate role play. I'm like allergic to role play, but I'm just going for the sake of this conversation and our amazing patients. I'm actually going to role play a little bit. But just okay. So the headline is right. I'm having shortness of breath. I'm going to say, and you tell me if I'm right on with this. I really appreciate it when my patients have a symptom story, which to me includes a timeline, right? So for me, I'm going to say I would love to know when it started, right? How it's changed, how often it happens, what impacts it. What else do you want to know?
I think the timeline in the story is important. Okay. And I think the other things that I would like to know is what has been tried, what are the things that you've been doing, and then how has it been progressing? Is this something that has been the same and the same severity, or it's been bothering you the same amount each day, or is this has been something that is progressing or you think is getting worse? I think those 2 things are really, really important. And just to give you a background, when Eve was saying, let's do a role play and shortness of breath, I was immediately thinking about, okay, what are the heart-related things that can cause shortness of breath, lung-related, blood-related. Exactly. And just to give you insight of the thing that we're talking about parallel processing. Exactly. It's ingrained to just be thinking about these different systems that can be doing it. But going back to your story, I think timeline, progression, and where they think things are going. Is it getting better? Is it getting worse? And what have they been doing to try to help it, or what has been tried, can really set the stage. So I think if you come in with those descriptors, with that story of timeline, progression, things you've tried, is it getting better or worse, it accelerates the conversation. And then we can really focus a little bit more on the back and forth. And then less time is spent having the doctor interrupt to ask, do you think this is getting better or worse? Because often that's some of the things that we want to know. Right. it gives more time for us to actively listen to the patient, which we all want to do.
Exactly, and have the conversation. I think sometimes I really like to encourage my patients when they're coming in with a new issue is to tell me right off the bat, tell me what you're most worried about.
Yep.
Because often I've had patients come in and, they're very, very worried. They have a headache often,
Right.
let's say. And what happens is that if they tell me their story, their timeline, and before I even ask more questions, I say, tell me just before we go further, like, what are you most worried about?
Yeah.
And often it comes out that they're worried about a brain tumor and they have a friend's parent who was just diagnosed. It really helps to me shape the conversation, provide often immediate reassurance, so then we can actually kind of have a more exploratory conversation when
I
people
agree.
share that right away.
I agree. I think one of the things, I know we've discussed this before, that I try to do, and we can talk about what we do to prepare for a visit. A lot of the preparation when you're coming to see a doctor, they're looking through the chart. A lot of it is, can I figure out what this person is going to want to discuss in a way?
That's right.
Right? It's like the headline. Can I figure out what the headline is?
Yep.
Sometimes as a trainee, I'm still going through this and developing my own practice, but what I try to do is to catch myself and just say, before I start asking questions, you're here in the cardiology office today, you're seeing a heart doctor. What were the specific things that you wanted to talk about first and foremost, right? And I think sometimes I sit back and I think about it after clinic. Like I was just in clinic on Monday with Dr. Lurie. He's lovely. He's a cardiologist at UCLA. Just a quick plug for him. It's surprising sometimes that I have to ask that, right? Because I think the point of something like this podcast is to make our patients feel comfortable setting the stage themselves. And I think so much of it, and as we're both patients, we've been on the others in the patient chair, is waiting for the doctor to start the conversation. And I think because it's a partnership and it's a relationship like anything else in life, it has to be two-way. So I think it's great when our patients feel comfortable doing that too. So I hope to those listening, you feel empowered to bring up the first part of the conversation in your clinic visits, because I think that's a great way to progress your care.
I think that is so great, and I think that's so important. I mean, and to our patients, this is your visit,
100%.
And even the word visit I really like, because again, like, this is a visit. We are supposed to be, talking. And it's interesting because, you have this cardiology training. I'm a primary care doc. Both of us are coming with and we just need to acknowledge them, our own sort of biases to the conversation, right?
100%.
Like, your instant framing you're going to have just some framing, and you can only be, aware of it. I'm going to have some biases as well. So I agree. I want to really encourage our patients. This is your visit. You can state the goal of the visit, what you want to, not only what you want to talk about, but what constitutes the satisfying visit, meaning, you can be very clear with us about what you're hoping to leave with, right? Whether it's reassurance, whether it's a game plan, whether it's, testing, whether it's just clarity. So this is really your visit. And so, Shaun, you mentioned, I think bringing, a timeline. And I think kind of with symptom tracking, we talked about. I'd love to know what you think, but I think photos and videos are very helpful, with certain symptoms, whether you have like rashes, probably in the cardiology realm, swelling. If you've had an intermittent like shaking, or the medical word for that is tremor, take a video of it. You can bring those to the visit. Any other kind of pre-work?
Yeah, I think now, especially in the age that we live in, like digital health,
yes,
that people are using, especially in the cardiology realm. We often have patients bring in Apple Watch data about things about their heart rate and whatnot. And I think as digital health advances, it's important. It brings an extra data point. And I think all of this is getting to the point of, when you're preparing for your visit with your physician, is how to bring in all the separate pieces of data into kind of a concise story that you can tell the physician when you come in, to help navigate that conversation. And our role is to sit, listen, and then pick up on the pieces that we think can lead to a connecting story of something underlying that could be going on, where we can help.
Exactly. We're going to sort of then write the story together.
Yeah.
Tell our patients what you think in terms of pre-visit artificial intelligence.
Yeah, I was actually thinking about this on the drive in today, about artificial intelligence, understanding that this is going to be something that's going to be a part and have a role in healthcare. And as patients and physicians, we should have an active role in discussing how to use it properly. So I was thinking, before the visit, especially if you're coming to see a specialist or even your primary care, I think using it to help you frame the conversation with who you're speaking to is really, really good. Because most patients, often at UCLA, see multiple providers, right? And as a human, I personally also have a hard time keeping straight who is who.
I like how you have to qualify that. As a human.
I know, right? That was a little bit odd, but it's funny.
I love it.
Sometimes it's hard to remember who is who, and I think it can help you. AI can be a useful tool in setting the stage of your whole medical team. And who are they?
Yes.
What are each helping with, but also help with the integration between medical providers. And what I mean by that is it can help frame the conversation to try to be a connecting piece for patients. For example, if you're coming to see a cardiologist, you could have a conversation with artificial intelligence or ChatGPT, for example, and it could say, the cardiologist may want to talk about starting these kind of medications for blood pressure. But remember, your primary care physician also chatted about these medications. We want to know how they interact. So can it help connect the physicians on the patient side? So the patients can come in being like, I know we're going to discuss this, but I want to discuss the fact that I just met with my other provider and they were thinking about doing this for my blood pressure. What are your thoughts about that? Because on the back end, we are doing that all the time after the visit, messaging your patient's other physicians to make sure that the care is as coordinated as possible.
Yes.
But the one place I think pre-visit that AI could help with is it could help patients integrate their doctors, and I thought that was like
I love that. I hadn't even thought of that, but that's exactly right. I mean, it's the same way of having, we talk about you can bring someone to the visit, right? To obviously prepare that, but a support person, I absolutely think this is a great support tool, and I didn't even think about that aspect.
Yeah.
But that's really great. I always think of using AI very well. I really, really like when my patients use AI, and then we look at it together and we address things together. I want us to diagnose things together with my human colleagues,
right.
But I think that I love the way
that you to use human.
Yeah, but I really do like when I use chat. Like, let's say I'm thinking about going and, let's say, visiting with a tax person or honestly like an auto specialist. I will write down all of the things that are on my mind, and then having the help organizing it and help framing the conversation is very helpful. The summary.
Yeah, I think the example I gave was a little more nuanced, but I think
I like that a lot.
I like the most standard case use is probably helping patients summarize the data. So you can have, when you come in to your clinic visit, you can have a quick summary of the things that you want to talk about.
Exactly.
And you can use AI as a tool to help organize that, like, top 3 things that you really want to talk about.
That's right.
So that you can facilitate that conversation. I think that's obviously probably like the best case use and the one that's probably the easiest. Yeah,
and I'm sure it will evolve. I have many patients who will, send me a note through the patient portal and say, "Listen, this is everything I want to talk about before I see you on Monday." I'm like, "Great."
Yeah,
it helps me get organized too.
I think so too. I think it helps streamline the docs pre-charting before the patient comes, or looking through the chart and making sure we discuss the things that we want to.
I love it.
Opening up, all this is coming back to the point of being transparent, right? I think a lot of the times as physicians, we're trying to figure out what that headline is going to be during the visit. And a lot of the times the patients, I can imagine, are coming in and they're trying to get to the headline themselves. So I think having more transparency about what do we want to talk about during this visit, or how do I want my care to look like, because that's different for each person, can make care and that visit much more personal, so it doesn't look the same person to person, and really holistic.
I think that's truly also the most fundamental, and it makes me think of, first of all, these are tools to be organized so that we can have these conversations. You can also come in and be all over the place, and we'll be all over the place with you. So it's fine, but I do think the transparency is essential. It reminds me, and that's why I so appreciate you sharing kind of, your childhood and, having these conversations, because this I think we both went into this profession because it is relationship forward. I wouldn't want to be doing this if I wasn't having, really honest, authentic conversations. That is the biggest privilege of this vocation and profession for me.
100%. I think sometimes I take for granted the fact that I can have conversations with people because I'm a doctor in a way that sometimes I can't even have regularly. And it's something that sometimes you take for granted, but you have a great ability just to meet people where they are and have really intimate conversations about their lives just to try to make someone feel better. Is a really special job.
It is very, very special. Okay, so now
if anyone wants to go to medical school, plug.
You should do it. I couldn't agree more. Okay, so we talked a little bit about prepping kind of for the visit, and we're talking about, sorry, I should have said this before, but a visit in an outpatient setting, meaning what we also say in medicine, ambulatory, so in a doctor's office or clinic. So although really you could apply these things to, a hospital room, but just for the sake of simplicity. So you're in the room, we talked about, setting an agenda, right? Or, so we could both kind of frame the visit. So, I think it's just really helpful. Sometimes people need a script. Things that you and I are comfortable saying, I really have to acknowledge, it's very, most people who come into a doctor's office, unless it's for a physical, are concerned, they're anxious.
Right.
Often they don't actually feel well. All of this kind of environment, emotional environment, makes it pretty hard to think clearly and advocate perfectly for yourself and be 100%. Really articulate. So what even just in terms of scripting, ways to just kind of start the visit or even set the agenda? Give us a script to steal.
Yeah, I think a basic script could be, like we said, let's focus on, Doc, these are the top 3 things I want to talk about today. I love that. And the second could be, let's start with the story of number 1, right? So let's talk about the first thing, which is my headache, and go into the description of the headache, and then just have the conversation flow. I think as the conversation would continue, if you have a long discussion about the top, and you only get to number 1 on that list, so be it. I think then you have a really fruitful discussion about the thing that's been bothering you the most. And then care doesn't stop there. If you need to come back, the doctor will already know then what are the other top 2 priorities that you need to have.
Yes.
And I think as a physician, I want to let patients know, I think we all understand how hard it is to set an agenda. And sometimes if you don't have that, that's okay. Getting to the hospital, driving in from far away, finding parking, all these things could probably make anyone's brain a little scrambled before they have to sit down and have a conversation. But if you can have a moment to just set aside a couple seconds to be like, okay, before I walk in this room, or using the opportunity once your vitals are taken in the room before the doctor's coming in, being like, all right, let's go through this playbook one more time. Doc, these are the top 3 things, 1 or 2 things that are bothering me. Great. Or these are the things that I wanted to discuss.
I love it. And I think, you mentioned about the transparency too, as we're having these conversations. Lots of times as clinicians, we're actually not sure what's going on, right?
100%.
And I'd love to know how you talk about uncertainty with patients without compromising kind of trust and expertise, but also so people feel, kind of oh, good, we're talking out loud together, but I'm also not totally freaking out because he doesn't know what's going on.
I think 2 things come to mind when dealing with uncertainty. One is, as a doc, I think I personally really lean on who's the person in front of me and what have they been telling me what have they been describing to me during this whole visit, where I can find out what's important to them.
Yes.
Right? So I think that's the first and foremost thing is, what can I take away from the conversation with the patient that I can tell matters to the patient? For example, for our patients listening, am I someone who would like less aggressive treatments or tests? That is something that's really important. Or am I someone who is very comfortable, because I really want to know what could be going on, to have something that could be a little bit more invasive? Or what I mean by that, a little bit more of aggressive testing.
Yes.
Just to see what's the context of their life. Is it hard to come to the hospital? Do they live close by? Is it easy? All these things go through my mind with uncertainty because it helps dictate what my recommendation would be and what are our contingency plans, knowing the context of that person's life and what they actually want with their care. So that's the first thing. Now I'm like blanking on what I was going to say.
No, but I appreciate you sharing. I appreciate you sharing that, and that you're even thinking about these things. And I think for our patients, it reminds me, the more that you tell us helps a lot. So the more that you will share about your lives, again, even everything from nothing is too small. Actually, everything matters. Exactly. Yep. So if it's hard for you, to get to clinics, to go to the lab, like tell us right away because we will amend and we'll navigate that plan with you.
And then the second one I remembered is essentially I'm going to take you through my thought process. Mm-hmm. I'm going to talk out loud.
Love it.
And I'm going to do my best not to use medical jargon and medical terms that are confusing, so that we can sit there and you can see my thought process, and I'm going to put it on the table.
That's right. And our patients can say, listen, talk me through it.
Yes.
Right?
Exactly.
Break that down.
Let me put my knowledge on the table and take you through the different algorithm I'm going down. And when we have multiple options, let's pick what's best for you as a person, right? So, these are the three things that could be going on. This is how we can get to each path. Which one works best for you? A lot of the times, though, if patients are willing to share a lot about what's going on in their lives and share a lot of information like you're saying, I might get to a certain path myself in my head and be like, listen, based off of what you're saying, because of everything going on right now, you just got out of the hospital, you're navigating a lot of things with family and work. Why don't we try this path? If it works, that's great. We'll have short-term follow-up, so we see you again shortly, and we can always pivot. We have a backup plan.
Yes.
Right? So it's like, how can I tailor things to people at the point of where they are in their lives, at the point of the visit, knowing that things change and we can pivot, but it should be personalized, ideally, to them. And then I think for patients to know, patients should be comfortable in knowing that if a doctor feels super strongly, right? If it's something that we think could be serious and we're like, hey, I know a lot is going on, but I would really recommend going down this path now, even though it might be inconvenient, we will say that, right?
That's right.
So if there's wiggle room to be had, then let's use that wiggle room and that slack to figure out how things work in the context of your life. But if there's urgency, and we go through that together, right?
Absolutely. And I think that, you basically gave us this fabulous example of basically what shared decision making looks like, which we've talked a lot about on this show. So, to me, you're saying, listen, from my medical expertise, this is what I recommend, but what works for you as a patient? But what I also heard you say, which I love, is we're not just saying what works for this moment, right? But this is going to be an ongoing conversation and dialogue. So the conversation we're having today, it's not a one and done, right? And we're going to, we all know that we go home and then are like, wait, what just happened? But also go home, talk about it with your family. Go home, do more research, bring it back. We're all willing to have this longer conversation over time. And I think, too, we want you to feel comfortable. And at the same time, we recognize that's easier said than done. You please say to us, wait, help me understand your reasonings. Can you point me to some, resources that I can kind of read on my own time? What are we watching for? What are my options? Feel free to ask all of those questions.
Yes.
It's about you.
It's about the patient. And again, it's about who you are as a person and how we can get there together.
That's right.
It's definitely a partnership. And I fully believe in shared decision making. Sometimes I wonder, this is a little bit going on a tangent here, where wouldn't it be nice that if your initial visit with a patient was kind of unless there's something urgent that we have to deal with, just a pure conversation about who that person is.
Exactly.
Where are you coming from? What's
Shaun,
your work,
you can go into primary care. That's what we do the whole time.
Well, I would like to think that even within specialties, we can take the pearls and the real clinical strengths of primary care doctors and incorporate it into what we're doing.
I promise you, everything I know about you, you will be doing this as no matter how specialized your cardiology practice is, you take the time to get to know people, and sometimes it's longitudinal, knowing people for a long time, but even just listening, you get a sense of, I get it. You want to sort of say, listen, I want to know who you are, historically, what preference, what have you been your preferences, like your family, your culture.
And there's been plenty of examples through my training where patient preferences dictates their care, right?
Of course.
And all of us as doctors have seen this, and patients, you may have seen this personally yourselves, where we can be much more precise with what we offer, and we don't do things that people don't want for themselves, and we only do things that people would like for themselves. And that's at the end of the day, that's all we want to do, is we want to make sure that anything we recommend aligns with what the patient would want for him or herself.
That's right, you and your values. And I'll say it plainly, not only are you allowed to understand your own care, you have to understand your own care. It's your body, you're in charge. But I think great docs like you are willing to say, listen, let me shepherd you through some of these decisions and these very complicated conversations.
Yeah, and I know, Eve, we've talked about this too, like when you're in a visit, a lot of the times I think another thing patients can ask before they go is like, okay, what are the top 2-3 things I can work on before leaving or before seeing you next, right? And I also think when we talk about AI helping you frame a script before you come in, this is another place where AI can help you remember when you're meeting so many docs and you have so many things going on in your lives, being like, oh yeah, my cardiologist wanted me to work on 5 pounds or like walking 30 minutes a day, a goal of losing 5 pounds before my next visit, and checking my blood pressure a couple times a week.
Yeah, I love the threes. I have 3 daughters. I do everything with threes.
Yeah, going back to the power of threes, and how that can help with communication. Like a simple 2-3 things.
Absolutely.
And what's our take-home message, I think is a good way for patients to be like, Doc, what is the take-home message of today's visit before I leave?
No, this is perfect. This is exactly what I wanted to ask you next, which is, the end of the visit and, leaving with the plan you can say out loud. Exactly, the top 3. And, you were already, even mentioning this already. I mean, a lot of medicine happens after the actual exam room encounter. So again, we know this too. The room is just one part, right? There's the rest of the world. And, we really recognize that. It's this big ecosystem of a very complex healthcare system, right? Which is, you're going to the pharmacy, there's side effects, there's questions, there's changing symptoms and messaging and paging, which we'll get to. But I love what you're saying. So before you leave as a patient, let's do that recap. I love the power of threes.
Yep. I think the power of threes are important. It's a way to just, all of us, doctors, patients, everyone, you only have the ability to remember so much, right?
Yes.
So, I think thinking about things in the terms of threes or a take-home message is a good way to frame and remember your conversation. And it's a way of remembering the most important thing. And I think that's a perfect way to go.
Yeah, the goal is not, there's no such thing, first of all, as a perfect visit, but definitely a goal is a clear next step. And I would say you as the patient, again, we're going to have to mix our agendas, and that's why we're going to talk about them out loud. You as a doc might have your agenda in terms of, how we're going to finish this, tests we're going to get. But I think as the patient, if you say, listen, I want to feel better, I might not even know what the diagnosis is, but if at least I want symptom relief, right, that's also a goal.
100%. I think that would be a great conversation to have at the end of like, okay, so what from today do we talk about the most? Is it this symptom? While we're trying to find a diagnosis, how are we addressing that symptom? And that's the takeaway. That's a great takeaway. Exactly.
And you mentioned contingencies, which is, to me, I think in plain language, like, listen, what happens if, right? And then, what's the plan? And so, to remind everyone, a good medical game plan isn't just you're just going to do this, right? It's also like what we're watching for, and if what we're going to do depending how things go. Yeah, and I think as from patient's perspective, it's okay to ask like what the backup plan, or like not even the backup plan. Please ask. What's the other options, right? So I think ideally we always try as your physicians to communicate saying, let's try this path. If this works, great, and we've gotten to the bottom of it, that's ideal. But if
this continues,
right,
we're going to do ABC next. Right?
I mean, and the number one, I will say this to my patients, this doesn't happen a lot in primary care, although, I get lots of pages and I love every single one. But I mean, I remember going home after, one of my deliveries and, I was like, wait, I don't know who, I started bleeding and I was like, I actually don't know who to call.
Yeah.
And so you can feel very free after, not only free, we're encouraging you before you leave a visit to say, if I have a question after hours, if I have a question on a weekend, what do I do and who do I call? I think that the mystery of these medical words that we use, coverage, on call, paging, like let's just go right there. I think a lot of people, worry about this.
Yeah, I think that's a really good point. One thing I would like to tell patients is it's okay, it's normal to leave a clinic visit and be like, oh man, I really meant to bring something up and I didn't.
Yes.
I will also tell you on the physician side, we also experience the same thing. The patient walks out and we're like, oh, there was something we really wanted to ask.
Yeah.
So I think what we're trying to frame is that the visit doesn't end when the door closes.
Exactly.
A lot of the times from a physician perspective, we'll be like, okay, there's something I wanted to ask, or there's something I want to run by my colleague and be like, hey, what is your take on this?
Yes.
Just to move care forward. So for patients, asking about who to contact, how to contact them is really important. And it's okay to have questions after the visit. When the door physically shuts on the visit, it doesn't really shut the conversation, right?
Yeah, I agree. I mean, I would say, not only is it okay, I'm like, I count on us having a dialogue because I'm sure this happens all the time. You might prescribe a blood pressure medication, and then I'm like, but I need to know if it's working and how you're feeling on it. So I want to hear from you.
Right, 100%.
So, let's talk about just kind of the quick translation of some clinic logistics, if that's okay. So when patients hear coverage, what does that actually mean?
Yeah, so coverage means which provider. So there's a group of providers. There's a group of doctors. So providers, physicians, doctors, all are synonymous, and you can and nurse practitioners, the whole team of providers. So a coveraging provider is someone at a certain time of the day who is fielding the calls on behalf of their colleagues. So a coveraging provider could be, say, I'm in a group of 6 doctors. You're coming in as a patient of our practice. You don't see me physically, but you see one of my colleagues. But let's say at 5 p.m., I'm a coverage provider. So when you call our office and you need to speak to a physician, you speak to me, who is covering the doctor that you saw on the visit.
That's great.
Yep.
It's perfect. And what about on call?
On call is essentially, at night, primarily, who is the person who's going to be available to answer emergent questions, especially things when we're thinking about, do I have to go to the emergency room, or I'm really worried something serious is happening.
Exactly.
Who can I get to help me navigate that situation? That's the on-call provider.
Exactly. And often, when I'm on call, I'll pick up the phone, and sometimes it's something I can just reassure.
Yep.
Often it's just me directing the person calling to say, listen, I'm covering for Dr. Ma. We do have immediate cares open, or this is something you need to go to the emergency room about. But I just really want to normalize to our patients, you are not being difficult, by reaching out. If you're worried, that matters, and if symptoms are changing, you don't even just understand what to do next. We really recognize how hard it is to navigate, and we really do want to hear from you.
Right, 100%. And I think the insight of you're talking to an on-call provider, to give a little bit more insight to patients, is a lot of the times what they're thinking about is like, okay, what are the emergencies that I have to be worried about? And is this an emergent situation? Right. So the conversation may be framed more about, is this something that I need to, as a patient, be worried about right away? And a lot of times the role of the on-call physician is to provide reassurance and be like, you're going to be just fine, and we will have a follow-up conversation with your physician. So just for patients to know how the on-call physician may be thinking.
Yeah. Oh, no, I mean, exactly. Yeah. Everyone's always so worried about bothering me. I'm like, we really bother me now.
Right.
I really don't mind. This is actually why we went into it. Remember I said residents, we used to live in the hospitals?
Right.
I don't live there anymore. You can call me. I'm at home. This has been so excellent. Is there anything I haven't asked you, though, before we get to takeaways that you wanted to mention kind of, from your perspective?
I I think I guess if we're talking about takeaways,
Yeah.
like one of the things that I would like our patients to know is the context of their lives really, really matters. And I think the more they speak about how their care integrates and is part of their bigger life and how their lives interact with their health, helps us provide more precise treatment options for patients and allows us to advance the partnership even further, and I think especially for first visits, I think it's really important to get an understanding of who that patient is, what their preferences are, both with their health and what they like to do and who their family members are, because all of those things are going to be important in their care.
I mean, that's a beautiful and perfect takeaway. Thank you so much. I really can't thank you enough for this conversation. We could talk for many hours more, so you're just going to have to come back. I really want to say I love hearing about your family. Your family must be so proud of you. I have to tell you that I'm very excited just that you're representing this newest generation of physician. It just makes me feel very, very hopeful. And I already have amazing, outstanding colleagues, but I do think that this emphasis on communication is something that it shouldn't sound, revolutionary, but I think that it adds a layer to just the expertise and kind of kicks up the kindness and compassion to this, really this next level. I really feel like you remind us that good care isn't just, the prescription.
Yeah, I really appreciate you, Eve, having this kind of episode because, again, for patients, the visit isn't the majority of what your doctor is doing with you. Mm-hmm. It's the majority of time that they're spending face-to-face listening and having an active conversation. But we're spending just as much time before the visit preparing and after the visit coordinating care. So as much as it may seem that 30-minute visit is the time you have with the doctor is actually thinking about you before and afterwards just as much, if not more. But yeah, thanks for having me on. And I have to say, shout outs to Dr. Watson and Dr. Yang, our fellowship program leadership, and Dr. Shu, our chair. I think I'm very grateful to people like yourself as well to be at UCLA and to be able to do things like this just to help the patient experience be better. We have
so much more to talk about. Don't worry, you have to come back. I think for our listeners, again, you deserve care that makes sense. You matter most. We really care about you. We really want to make this system work for you. And I think that the take homes that Shaun was mentioning about preparing, partnering, recapping. But I love that the listening, that again, there's a dialogue that we want to have with you, really just going forward indefinitely.
Yeah, and for patients, medical trainees care about you just as much, if not as much or more, as the attending physician. So if you have a medical trainee, it's okay to ask what part of their training there is, but just be reassured that they're there to listen to you, that you have a second set of eyes. And to all those who are going through medical training, as someone who is just finishing that up and starting the journey of being an attending, thank you for what you guys do. It's a lot of hard work being a resident, a medical student, a fellow, and it's a really long journey to get to be an attending. So thank you to all the medical trainees to help take care of our patients.
Hear, hear. Thanks to our listeners. Shaun, a million thanks to you.
This was fun.
Until next time, stay curious, healthy, and take good care.